As you've heard, I have the pleasure to introduce our special guest for this fireside chat, Andy Slavitt, who's the administrator for the Centers for Medicare and Medicaid Services. My last admonition before getting up here from Andy was to not read his whole bio. So I'm going to have to think on my feet very quickly here so that I can still touch on his bio so you understand and know his background and who he is, but not get him riled up when he comes up to the stage. And the reason for that is that the person who leads CMS is maybe the most important person in American healthcare. For those of you who are not aware, the programs that CMS oversees provide access to healthcare for 140 million Americans, including Medicaid, Medicare, the Children's Health Insurance Program, and the health insurance marketplace. Since 2014, when he joined CMS, Andy and his team have focused on all aspects of the CMS scope, including improving quality and outcomes, access, payment reform, improving the performance of the health insurance marketplace, which has had a bumpy ride, improving affordability, equity, and protecting program integrity. An enormous and comprehensive agenda, and one that is, I think, clearly we would all recognize important and making progress under his command. His ability to spearhead complex management challenges stems from his background as a leader in healthcare and technology, with the vast majority of his experience acquired in the private sector. So his focus on improving customer experience, access, data use, and transparency are all very useful experiences to bring to bear on the job that he is now taking on. His track record of successfully delivering and improving these programs will benefit the health and well-being of millions, as I've said. So just to tiptoe across his bio a little bit, Administrator Slavitt was a very significant player in the company Optum, which I think is familiar to all of us around clinical technology and operational solutions in healthcare. He also had some time in the consulting world with McKinsey, and has a sterling blue chip educational background with a Ivy League flavor to it, shall we say. I hope that's concise enough. At a recent healthcare conference, Andy commented that healthcare needs a more modern infrastructure, and I would say a strong here to that, that we need the healthcare system to adapt and learn, and the way in which we use technology to improve our productivity and reduce our costs is key to that. So we're delighted to be able to hear his perspectives today. I think Chris already touched on Meg Tirrell's role. She is going to moderate this session. She covers biotech and pharmaceutical industry for CNBC. So thank you both for joining us.
Is that what you usually get?
Well, there was Flight of the Valkyries was played earlier. I thought that was pretty cool.
Nice.
Yeah. So sitting here with the most important person in American healthcare, I got a little nervous hearing that in the introduction. But we heard a little bit about your background in the private sector from Optum, but also McKinsey, and before that Goldman. Maybe you can tell us just about kind of the path from the private sector into the job you're in now.
Yeah, it won't surprise you that I'm not even the most important person in my house. And I'm sure many of you can relate to that too. So I ended up here at in the government. I got involved leading the turnaround effort for healthcare.gov. Does anybody remember? Healthcare.gov didn't go quite so well. And we raised our hand, and I came in and worked alongside the administration, really to sort of rapidly turn around website, I think for a lot of reasons, but particularly because I think it was a we can't fail moment in terms of making sure that not only health care reform could start to move forward, but people could see the government could work. And what hit me hard at the time, and I think what caused me to stay, was that it was very clear we're moving away from the talking about health reform stage to the doing it stage. And I'm sort of one of those people that believes it's all 90% about implementation anyway. And it was, I think, becoming clear to everyone that whether it's delivery system reform or how we cover people in America that haven't had insurance coverage before, how we do it and how we all do it together was really the fun part. And so that's how I ended up deciding to come take this on, and been doing it ever since.
Now, when you say we're in the doing it portion of healthcare reform, how would you characterize the progress we've made and kind of where we are in that process? How much further are we going to see reform?
Sure. So, when I look at what we've done over the last 6 years since the passage of the Affordable Care Act, and I sort of take stock, 20 million more people have coverage today, and there's evidence that their lives are immeasurably better financially, better health-wise, they sleep better at night. So that's one wonderful start. From a quality perspective, I think we got some tools in the ACA to really take a look at making these efforts that we talked about for years on quality to finally make some progress. And I think we've seen, by many measures, a lot of progress. 17% reduction in hospital harm, to name one. 105 out of 110 quality measures across the country have gone up. And we are managing this to deliver this 25% below what the CBO estimated. And we are managing to deliver this still at, I think, record medical trend growth. Now, I think all that's a start. I think all that it should be a sign to us that we can make progress, because if you look at any of those curves I described, over a 20-year period, you'd see that they hadn't moved at all. And I think for the first time, I think all of us can look around and say, absolutely, progress is possible. However, the things that we have to do from here, I think, are not going to be the same things it took to make this progress. I think we are going to have to do a lot more and to challenge ourselves a lot more to commit to how we collaborate and how we commit to affordability, because I think the path in front of us requires more and better execution.
What do you see as some of the most urgent next challenges to tackle?
So, I think there's a couple of things that I think, ways I would answer that question. I would start with the fact that we have, you take the population that we're responsible for, CMS and Torch. Can I call you Torch? Is that right?
I think he prefers Big Boss, actually.
Right. So you think about 140 million people that are in the Medicare, Medicaid, CHIP, or Marketplace programs. And you think about what their lives are like, every day. And it's incredibly diverse. And we have people that are trying to get out of nursing homes and be treated at home. We've got people that are going through massive care transitions that aren't anchored to a particular place in the system. We've got people that are getting covered for the first time and have had symptoms that they've never checked before. We have a growing prevalence of chronic disease and cancer and central nervous system diseases. Just a massive array of needs, and we have a community of people that are aging rapidly. The Medicare program in the next 15 years is going to double the number of people over 85. So it's very clear that we're going to have to find ways to take care of people better, more efficiently, more simply, more comfortably in environments that they prefer. And I think understanding that consumer need, I believe, is the key to beginning all of it, because what it will tell you is we need to focus on how we coordinate care better. We need to focus on how we treat people in lower cost, more comfortable settings. We need to focus on how we take care of the most difficult to take care of people who are on the lowest incomes with the most significant challenges that are most disconnected from the healthcare system. If we do that next, and I think, as I said, there's lots of evidence that we know how to make progress, then we are going to, I think, set this healthcare system on a course that is sustainable, but also one where we are going to be increasingly comfortable getting care in, and I think that's going to require change.
I want to ask you about cost containment broadly, but one issue is drug pricing, which is something that's entering every conversation we have about cancer. At ASCO last year, we started talking about financial toxicity as this new side effect. I'm sure you talked about that today as well. What is your take on the drug pricing issue? I think you've kind of been outspoken that the government needs to maybe lessen its posturing toward the drug industry. Tell us about your thoughts on this issue.
This is a really interesting test, I think, for all of us, even beginning with how we talk about and how we decide to address this issue. I mean, clearly, we're all very invested. I mean, clearly, we all are very invested in multiple ways in this issue. And the way I look at this issue is, I'm going to be in this role for less than 9 months. So in many ways, I feel like I'm working for my successor. And my successor is either going to say that Andy gave me some of the tools I needed to help navigate the challenging circumstances of today, or he didn't. And I think the way I look at this question is, as a country, how do we have the things we want? Number one, how do we have all of the things we need for a good innovation climate, which means we have a predictable set of rules, we have a way of people winning, we have a climate where people can invest, and then at the same time, how do we make sure that all of the great work that the scientists and our drug companies and the NIH work on every day can be accessed by the people who need them the most? And we're already into this problem. Hepatitis, if you're a governor and you're trying to figure out how to provide hepatitis C cures that are now available to your population, you have to figure out how you're going to afford to do that. You're going to have to figure out when your budget is basically education and healthcare, some transportation, and some prison systems. So there's not a lot of magic pots of money. So it's an important thing for us to debate, and I will reject the notion on either side that we need to just focus fully on affordability, or that if we focus on affordability, we're going to discourage innovation, because I don't think that's the way it has to work. So the question is, what are the sets of ideas, what are the things that we can be looking at that will be the tools that will help us address this issue over the long term? I mean, we can all do math. We all understand that we can't, if something grows at 10% a year, it can't do that for very long unless it's reducing costs that are 11% somewhere else. We all understand that math, and the sooner we kind of look at that and say, where are the opportunities? Is it in value-based payment models? Is it in other ways of understanding how incentives in the delivery system work, where once the drug leaves the pharma company, there's a PBM and there's a whole value chain that has to play out. We have to be able to look at all of that stuff, get all that information, and then we have to run some experiments. We have to run some pilots. We have to try to figure out what works. And I think that's something we all have to do, I think, together.
Do you think the focus on drug prices is appropriate in relation to the focus on other costs in the healthcare system?
So I think it's appropriate in the right context. So so I think, again, if you have, I think roughly 17% of costs now are drugs and drug related. I don't care if that number is 25%. If I'm keeping people out of hospitals, allowing them to live longer lives, allowing them to play with their grandchildren, keeping them out of nursing homes, allowing them to stave off, the conditions. That's all great. But I think that implies an equation that we all have to address. And what do we get for our money is a very important question for all the taxpayers, for all of us to look at. Today, I don't even think we have a common language. Today, if I asked you what does Sovaldi cost, if I asked anybody in the room, some people would say 80,000, some would say 90, some would say 30, some would say I heard someone's paying 50. There's not even a common vernacular. So we're in no danger of overdoing the focus at this point, I would argue.
How do we fix that?
Again, I think we fix it a couple ways. There's a couple areas of common ground, and I've been spending a lot of time with talking to people in the industry, getting all kinds of perspectives. They spend a lot of time telling me what they think, and I think people have a lot of important perspectives here. One of the things I think you have to do, Meg, is you have to make sure that you start with a common language where people have an understanding of what actually is happening and what you're getting for it. So, as an example, if you have stories of a drug where the price is being increased astronomically, that becomes the story today. That becomes the story. So as long as an industry is defined by one bad event, it's not in a particularly good place of equilibrium. So what is the information that we all need? What is it that we all want to understand? And then I think we can work on those types of solutions. In the case of hepatitis C, is another example. Wrote a letter to all of the states and reminded them of their obligation to provide this life-saving coverage to the people who need it. But I also wrote a letter to all of the suppliers who manufacture the drugs and said, come to the table, and in exchange for a bigger market, and there's some evidence that half the market is being left behind, you can put together a price point that states can afford. Because I can tell you, if you're a state, a mid-sized state, $400 million surprise line item is a hard thing to deal with. And what I know is that you've got states that are right next to each other that are paying dramatically different prices. So that's not how it's supposed to work. And in Egypt, this drug is available for like a fraction of the price. Well, the poorest people, the lowest income people in this country can't get access to the drugs, and people in Egypt can. We can do better. So there's not a lot of, I come from a private sector where we do deals all the time. There's plenty of overlap. There's plenty of ground to do deals here where people can win, but they have to come to the table and not retrench. And that's why I say it earlier. This is a test. And the test is, do we retrench and resist the dialogue, or do we engage in the dialogue? And I hope that we engage in the dialogue.
What are some of the pilot programs you were mentioning before that you're most excited about in terms of accomplishing cost containment and dealing with the number of people who are going to be on Medicare, but at the same time enabling and spurring innovation?
Yeah. So I'll talk about a couple things. If we think about chronic disease, right, which is, I think, what the people in this room spend a lot of time, a lot of brain power, a lot of money figuring out to help us combat. What are the efforts and what are the ways to go at that? And I'll tell you three of the things that I think are really important for us here. The first is, I think, really doubling down on primary care. And I think you've seen it several weeks ago, we rolled out a model which increases what we pay to primary care physicians, gives them a lot more flexibility in how to spend it, but really to try to reinvigorate primary care as a practice, but also as a process for people. We have just announced that the diabetes prevention model is approved and authorized to be expanded to the entire Medicare population. So moving towards primary care, moving towards prevention, and I think public health and vaccines are all critical. There's also obviously an important role for innovation and how we, on top of that, can innovate to do this. But again, I think in this spot, you're very conscious of the fact that if you're increasing somebody's revenue, and ultimately we're not improving some other outcome for the patient and reducing burden on the system somewhere else, you can only do that for so long. And I think so approaching, I think, these problems in a way with a understanding of what are you going to get for your public policy, and what can the private sector do, and how can they play? I think there's loads of opportunities.
Given we're focusing on cancer these couple days, are there specific programs in this area you think will make a big difference in terms of ideas like bundling payments and things like that?
Yeah. So in oncology care, we were just talking about this at our table. I think we have a very promising model for oncologists. I think this is a model that allows for, we have to get back to a place where we allow physicians to do what they do best, which is kind of manage the complete care of a patient coordinate that care where they need to, and not so much focus on, the different ways that the system has allowed them to get paid and to make money. And I think we have a very intelligent model that we're launching on oncology, and we have to see how it goes. But I think one important sign is the oncologists are responding favorably to it. But I would also just take a step back as we think about all these models to remind us of something, which is we are really in what I would consider to be generation 1 or maybe generation 2 of these models. I mean, it's sort of like imagine that you had the iPhone 2 in your pocket instead of the iPhone whatever you have in your pocket. We are still at the learning stages, and I think our commitment, and one of the things that I've tried to bring to CMS, is this focus on what I call user-based policy design. So we go in, we launch a model, we learn, we see what works, we see what doesn't work, we take a lot of feedback, take a lot of beatings, but ultimately, you listen, you learn, and you evolve these models to a place where they work. And if we can be committed to doing that, and we can be engaged with the community, and that's the one cultural change that I am hoping that as I leave CMS, next January, continues, because it's critical. It's too easy to sit in Washington and make policy and think that you've got it all figured out. It's another matter to go see where care is practiced, go see where care is delivered, to engage with patient groups, to engage with physicians. And when you find out that your brilliant idea turned out to be a regulation that landed in the compliance department, you start to see that this chain works very, very differently. And then when you see what actually does engage physicians, which is more freedom, more control, less burden, it's quite exciting. And I've seen our staff get really excited by some of these new models that accomplish that. So we have to continue to iterate these things to make them work better.
When you look outside the United States, are there models elsewhere that you like, dislike? I mean, comparing us to Europe, say, are there things there that you like? Do you see us evolving more toward what we see there, or staying on a completely different track?
Boy, I'm gonna say we have. I mean, healthcare. I couldn't even tell you that healthcare in Texas and healthcare in California they oftentimes have as much that's in common with what's local than what connects them. And I think it's always great idea to see what's going on in different places and see what ideas you can borrow and so forth. But we have a really unique system. We have a really unique system, and it's a system that can work. It's a system that can work if we collaborate, focus, share information, and put the patient at the center. So, I think we actually have a better, more visible path to how we do that today than we did 5 years ago. And we'll have a better view of it 5 years from now. And if we put the right infrastructure in place, particularly to treat the most difficult to treat patients, I think the answers are more in front of us. So I think we have models around the country that I probably think are worth paying attention to more than I would say I'd point to something in Europe.
Any specific ones you'd want to highlight here in the U.S.?
Oh, sure. I mean, I think Massachusetts. I mean, this is a place where so much happens from a population health standpoint, from a bundled payment standpoint, that I think really have opportunities to work and to flourish. The way you can look at these models a lot of different ways. I think of them as change management tools in many respects. And different parts of the country are accelerating. I think Massachusetts would be a great example of that. But how do we then take those things and put them in places where physicians have no experience managing a full population, or where they've never had to think about a bundle quite in the way that they do here, where you have to really be accountable not just for the surgery you're doing, but for all the post-acute care, and where you have to get invested up front in all the prep work. So these models, you put them in place, not because we think they're going to radically and amazingly change the way the healthcare system works and the way the program works, but because they allow everybody involved, physicians, hospitals, rehab facilities, others, to communicate in ways around the patient that they never have before.
I think we might be getting close on time, but I want to ask you one more question. You mentioned you're 9 months left in the job. You see your job as leaving, leaving your job in a good place for the next person. How much could the shape of healthcare change based on who's in that job and in a higher up job come January?
Yeah. So a couple dimensions to that question. One of them's a political dimension, which I think is great fodder for the bar tonight for everybody. Maybe I'll answer the question this way, Meg. First part is, if any of you have ever thought about public service, the government needs people from the private sector, and I'll tell you why. The right kind of person for a job like this one is someone who doesn't really need the job, doesn't really view it as a stepping stone, doesn't really care if they're making friends, because it's really hard to do in this job. Although I think we made a few friends. Don't we think we made friends in lunch, Giovanni? You'll find out when you hear from Giovanni whether we made friends or not. And I think who knows what it's like to struggle to find the care they need, or to struggle what it's like to be able to provide the care they need because the system was holding them back. And almost regardless of the sort of political overhang, I hope that whoever is putting someone in this job and the secretary's job are really focusing on those kinds of attributes, because we are going to be so reliant on having a transparent system where we connect to one another and where all of you know what's going on inside government, and where government is able to communicate better with all of you in order to be successful, that I think that's part of the ticket that I hope continues.
Are we out of time? Oh, I didn't even see. The table was blocking it. Oh, we have lots of time. Great. Well, then I can ask you.
I almost escaped.
Well, actually, I'm really glad we have more time, because I was thinking, oh my gosh, we were talking a little bit about cancer, and this is a cancer conference, and we didn't get to talk very much about it. So I'd like to go more into some of your cancer models. And I know I was kind of emailing with some folks about what they might be interested in hearing from you about. And one thing a lot of folks mentioned was this idea that we have all these very exciting new cancer drugs, a lot of which you've been talking about today, and a lot of them will be combined with each other. And this goes into sort of the answer you were giving earlier. But how do you think about paying for these new cancer drugs, especially as they're going to be given on top of each other?
So I think the initiative that we think about, there's a couple things, obviously, that you hear the government talking about that I think are relevant to this question. One of them is obviously the moonshot effort, and sort of how we galvanize together all of the research and all the work and the information at a national level. And I think that's incredibly exciting, and you can see and feel the energy around it. The other is precision medicine, and I think a very astute connection point that the president has made to the fact that we're not treating average patients any longer. We're not treating average patients in the clinics. We're not treating average patients with the medicines that we make. We're treating individual, specific human beings with very specific sets of needs. And the more and better we understand that, that's really where the future is. So that is a dialogue and an effort where, from your perspectives, as you think about the various kind of hurdles to development on the R&D side, and safety and efficacy, and how that combines with pharmacoeconomics, safety, and coverage decisions and determinations, clear to me that between the NIH and the FDA and CMS, we have an opportunity to work together and rethink how we connect to innovators, and to focus on those models and those areas. So it's a space that we all talk about collectively and plan for, but it's one that I think is very, very early. And I don't think there are a lot of developed answers yet. It's one of the reasons why I think having a model, a value-based model, and maybe I can talk about what that means, but where drug companies and innovators can get rewarded when patients get their cures or get their desired outcomes, but where the government isn't paying when there's no response or no reaction, so that we can develop targeted diagnostics and all of those kinds of things. So really need to be thought through, not just from how do you pay for it, but what are the intended and unintended consequences of setting up these models so that you can get more development and more care that's needed. I will tell you, I walked through a nursing home several months ago. 60% of the people had Alzheimer's or advanced dementia. I understood from talking to some of the family members that they'd all lost their spouses to either cancer or heart disease. We have to, so I'm enormously bullish behind how we figure out how to innovate for folks. And that's, I think, one of the reasons why starting this dialogue now, getting to some landing places now on some of these models is so important. I would predict that if we don't do things now and we start to address the cost and price and value issues 5 years from now, the window will be shorter, the solutions will be more desperate, and they'll be more radical.
Well, let's talk about what the value-based model, I have 1 minute, 30 seconds, what the value-based model means to CMS. And do you think it means what the industry thinks it means?
What do you think it means?
Luckily, I'm the moderator and I don't have to answer these questions.
So I'm not having taken a poll of the audience. I thought you could speak for them. I would say, Meg, that what it really, I think, means in the hospital and physician space is maybe a good place to start to look at, which is there's really 3 types of value-based models for hospitals and physicians. There's bundled payments, there's primary care-based models, and there's population health-based models. And the way all of those models work is if the quality outcomes are better, and it's done at an efficient cost, then we pay more. And that is, if anything else, if nothing else, is a reinforcing signal as much as it is I hope it's not viewed as a way of sort of gaming how do I mechanically do things so I get paid. I think the leadership that exists in great places like Mass General and in the great life sciences companies across the country and across the world, they're looking to do the right things anyway. We need to reinforce those things. So if you have a drug that works, that cures 30%, it's a 30% cure rate, and then I think a value-based model, and very simply stated, is making sure that you pay where it works and you don't where it doesn't, or that you pay additionally when you achieve outcomes that are defined, whether they're reducing bed days or whether they're quality adjusted life years or however that works. But it's a whole open landscape, and I think what I would leave everybody with is nobody's yet done 1.0 version of what an ACO is or a medical home in the therapeutic space. So that's the opportunity. What will that look like? Can we create those first experiments and see which work and see which have legs and see which are successful? It's obviously, to your earlier question, it's done all over the world. It's not done here. So I think a lot of the pharma companies and life sciences companies know how to do it. And a lot of them are educating us and, quite frankly, asking us to figure out how to develop it, because I think they want a sustainable answer that will keep investments coming, will allow them to keep putting money in R&D, which is what we all want, but also understand that that's a rational, sane way where we can continue to serve and meet the needs of many more people.
Well, this has been fascinating. I wish we had another 5 minutes stuck on there, but unfortunately we don't. So, Andy, thank you very much.
Thank you.